Hi everyone, I want to talk to you about anorexia nervosa. Anorexia nervosa, but I'm going to limit this presentation to treatment only. I'll make a separate presentation on anorexia nervosa generally. When it comes to anorexia nervosa treatment, the onset of the treatment should be non-pharmacological, and that should involve making a joint decision with the affected young lady, because since we want a good outcome and we want her involved, she must be involved from the beginning. We should also involve the family members, but that must be after the affected young lady has consented to that. There should be a good doctor-patient relationship to get a good outcome. Our focus should be on weight gain and nutritional replenishment. We should supervise the feeding at onset, but we may not be able to rule out tube feeding because tube feeding is possible if the affected young lady will not on her own take prescribed food. You can use the Ensure, Boost, and so on. We should ask about laxatives usage and gradually tail off the same. We should counsel against purging and binge eating. People that are on anorexia nervosa treatment may be relapsing when they continue the same practice, binge eating and purging. We should counsel against that. We should encourage the affected young lady to rest more than exercising, because they were exercising more in the past. That's why they're down with this problem now. The weight gain goal should be 0.5 to 1 kg per week, depending on whether they are on admission or not. If they are not on admission, 0.5 kg per week is fine. But if they are on admission, 1 kg per week will be appropriate. If the patient is suicidal, we have to refer immediately. If patient is pregnant, we have to refer appropriately. If there are serious medical conditions like arrhythmia, severe electrolyte imbalance, we have to refer immediately. The pharmacological interventions will involve Cyproheptadine at the dosage of 2 to 8 milligrams per hour or sleep. That will serve as both appetite stimulant and hypnotic. Zinc gluconate could be given for the purpose of increasing the weight. And we have to replace any electrolyte imbalance like decreased sodium, decreased calcium, decreased potassium. And Olanzapine will increase weight, will decrease psychotic features, but we need to watch out for the possible complications or side effects like extrapyramidal signs. Benzodiazepine, example, lorazepam or clonazepam for anxiety treatment, metoclopramide to handle the nausea, and at the same time it's going to help in increasing kinesis. Domperidone to increase gastric emptying, that is going to prevent the feeling of fullness. Erythromycin, so many people will say erythromycin is an antibiotic, so why erythromycin in anorexia nervosa? Erythromycin actually can increase gastric emptying as well. So if you don't want to use domperidone and you are running away from the side effects of metoclopramide, you can use erythromycin for the same purpose. Thiamine is vitamin B1 and it's going to be deficient here. So you can give thiamine to prevent Wernicke-Korsakoff encephalopathy. Prucalopride is good for constipation. Lactulose is also good for constipation. Domperidone, like I've said just a while ago, will increase kinetics and thereby increasing gastric emptying. And erythromycin will also increase kinetics, reducing gastric emptying time, then enhancing gastric emptying. Metoclopramide will prevent nausea and vomiting, and at the same time can increase kinetics. So the rate of gastric emptying will increase. So decreasing possibility of constipation, decreasing the possibility of purging. Thiamine, like I've just said, will replenish vitamin B1, and you have to give it before you give glucose. You don't give it together. And that will prevent Wernicke-Korsakoff encephalopathy. IV fluid if hemodynamically unstable. Glucose if hypoglycemic. Olanzapine and quetiapine if psychotic or anxious. Clonazepam for anxiety. Zinc gluconate to increase weight. Trazodone for insomnia or sometimes for depression. And Cyproheptadine as appetite stimulant, Olanzapine for depression. Even some use fluoxetine and so on. In conclusion, it is very difficult to treat this condition, but we can assist the affected individuals by carrying them along. Anorexia nervosa can kill. I'm going to make a separate presentation on full details as per anorexia nervosa and bulimia nervosa, or eating disorder as a whole. Thanks for listening to my presentation. Kindly subscribe so that you can get these pieces of info immediately they are published. Thank you.